Little Leaguer's shoulder, a brief video. Little Leaguer's shoulder, a brief video. This video has been produced from an article source. See below citation. Proximal humeral epiphysealosis, colloquially termed little league shoulder, is a stress injury of the epiphyseal cartilage of the proximal humerus that occurs exclusively in athletes whose growth plate has not yet closed. It classically affects youth baseball pitchers between the ages of 11 and 16, though theoretically, it could happen at any age up until growth plate closure, which typically happens between the ages of 18 and 21. Although this condition is typically described in youth baseball players and throwing athletes, there have also been cases reported in competitive gymnasts and tennis players. This activity describes the pathophysiology, evaluation, and management of proximal humeral epiphysealosis and highlights the interprofessional team's role in the management of this condition. Introduction. Proximal humeral epiphysealosis, little league shoulder, is a shear or stress injury of the epiphyseal cartilage of the proximal humerus. Little league shoulder has also been referred to as osteochondrosis of the proximal humeral epiphysis and rotation stress fracture of the proximal humeral epiphyseal plate. Little league shoulder occurs exclusively in athletes whose physis remains open before the closure of the growth plate, and it classically affects youth baseball pitchers. Since growth plate closure occurs between 18 and 21 years old, injuries can theoretically occur until that age. However, the typical age at presentation is between 11 and 16 years old. Although it is typically described in youth baseball players and throwing athletes, there have also been cases reported in competitive gymnasts and tennis players. Etiology. Little league shoulder is the result of excessive rotational and distractional forces that occur with repetitive, overhead throwing. This repetitive microtrauma leads to cartilage damage of the proximal humeral epiphysis. It is believed that the rotational force has a larger role than the distractional force in developing the condition. The epiphyseal plate is at increased risk for injury because it is weaker than neighboring ligaments. This distinction is significant and explains why this age group is more likely to suffer growth plate injuries, whereas adults would suffer tendon or ligament injuries. The epiphyseal growth cartilage is also at higher risk for injury due to repetitive action than adult cartilage. Another factor increasing the risk of injury in adolescence is bone growth, which can cause strength and flexibility imbalances. Additionally, the growth plate is more susceptible to torsion than it is to tension. Pathophysiology. There are two broad phases of the throwing motion. These are the arm cocking phase followed by the acceleration phase. The pathophysiology leading to little league shoulder is believed to be the significant external rotational torque on the humeral shaft during the final part of the arm cocking phase, just before the acceleration phase. This torque likely leads to the deformation of the proximal humeral epiphysis cartilage, which eventually leads to proximal humeral epiphysealosis. As mentioned above, the distractional force has a lesser role than the rotational force. The distractional force that occurs during the throwing motion results in the rotator cuff muscles causing a force on the proximal humerus to keep the glenohumeral joint intact. The rotator cuff muscles exert a force on the proximal humerus because their insertion site is proximal to the proximal humeral epiphysis. Anamnesis and physical examination. During an examination of a child suspected of having little league shoulder, it is important to ask about a history of shoulder or elbow injury. Shoulder and elbow injury history are both important because they could both lead to a child consciously or subconsciously change their throwing mechanics to ease prior elbow pain. Altering mechanics may increase the risk of injury by distributing forces throughout the humerus differently. The examiner should also ask the patient if they have had a recent growth spurt, as this likely places him or her at higher risk for proximal humeral epiphysealosis. Symptoms typically include a progressive onset of generalized shoulder pain when throwing. As symptoms advance, pain can develop with simply lifting the arm. There may even be pain at rest. However, until the late stages of the condition, the patient will likely report that symptoms improve with rest. Additional symptoms can include diminished throwing accuracy and/or velocity. Up to 13% of patients can have elbow pain in addition to shoulder pain. On physical exam, patients are often tender to palpation over the growth plate on the lateral aspect of the proximal humerus. There may be subtle swelling. Otherwise, inspection and palpation are generally normal. Decreased range of motion and muscle weakness can also be present depending on the severity of the case. Most frequently, weakness is due to guarding secondary to pain. Evaluation. Diagnosis is primarily clinical suspicion. In most athletes, radiographs will show a normal physis. Diagnosis can be confirmed by radiographs, which may reveal a wide proximal humeral physis on an antero-posterior (AP) view of the shoulder with the arm in external rotation. Chronic changes such as sclerosis, demineralization, and fragmentation can also be seen. Musculoskeletal ultrasound can also help diagnosis in the hands of a practitioner experienced with musculoskeletal ultrasound. Ultrasound findings include increased hypoechoic swelling around the affected shoulder, which is not seen on the contralateral side. Although often unnecessary, MRI can be used to confirm the diagnosis if X-rays are negative. MRI would reveal edema around the physis. Treatment. Management. If treated at the onset of pain, discontinuation of activities that cause pain can prevent an overt stress fracture of the proximal humerus's growth plate. Prior to stress fracture occurring, pain often resolves with rest. Once a stress fracture occurs, the pain does not resolve with rest, and the skill level while throwing decreases. The treatment for little league shoulder is 3 to 6 months of rest and discontinuation of overhead activity. Treatment can advance to core muscle and rotator cuff strengthening with a physical therapist once there is no pain at rest. Once the range of motion, strength, and scapular motion returns to normal, then a gradual return to throwing by participation in a structured throwing program and subsequent return to competition can follow. Surgery is not indicated for proximal humeral epiphysealosis. Thanks for watching. Orthopedics Trauma in YouTube. Subscribe. Orthopedics Trauma in YouTube. Subscribe.